First off, thank you so much for inviting me to participate in this. I acknowledge that even though my title says women's cancers, actually, I changed my title to breast and gynecological cancers because I acknowledge this is not just a problem that affects women. And as you know, male breast cancer is fairly rare. But for the purposes of my talk today, I think the color that I wanted to bring is that from a treatment perspective, there are not really a lot of differences. And I think what I'm hoping to share with you today is what we, along with the company that I work for, are really trying to do to impact outcomes in breast cancer in general. So that's the focus that I'm going to give my talk. And again, even though this is very general, please, by all means, this also apply to male breast cancer, and all the clinical trials that I'm going to share with you today and the ideas, the research ideas, whatnot, they are applicable to both men and women. So with that, let me go ahead and share my screen. Yes, no? Okay, perfect.
Yes.
So the title of my talk today is Transforming the Paradigm of Breast Cancer. And again, this is not a small feat. I mean, there's a lot we need to do. I think we've come an incredibly long way in treating breast cancer at large, because it is one of the first diseases in which we clued in that there are drivers of disease. Let me give you an example. Estrogen receptor. It's something that really drives the outcomes of certain breast cancers, and by treating patients with breast cancer with anti-estrogen drugs, we actually can incredibly augment survival, improve outcomes, and whatnot. Then over time came things like HER2, where we discovered that, again, the HER2 oncogene was something that was a driver of disease. And while patients used to do really poorly with anti-HER2 drugs, that has actually changed. So I think in cancer in general, we've moved from treating one size fits all to really trying to parse out things in a way that is smart, relevant, and really trying to understand this is biology in a way where we can optimize what we do for breast cancer in general. So let's acknowledge that throughout the world, breast cancer is the most common breast cancer out there, the most common cancer out there. Male breast cancer is obviously uncommon, but nevertheless, collectively, this is a disease that plagues a large proportion of patients throughout the world. So from an overall perspective, we as a company, we really would like to change outcomes in patients with cancer throughout the world. If you focus on the second row to the right, you'd see that the aspiration is that with our portfolio of clinical trials and drugs, whatnot, we really would be able to impact an incredibly large amount of patients by potentially treating 1 in 3 patients with a drug from our portfolio. And the way we would think about this is by acknowledging that cancers depend on a lot of different things to get going. And it would be smart to deploy different angles, different ways of tackling why a cancer progresses or what happens in there. So in our portfolio, we have very different drugs that actions. We have drugs that are antibody drug conjugates. We have drugs that affect DNA damage response, which is very relevant for patients that have BRCA, PALB2, or CHEK2 mutations. We have drugs that target tumor drivers of resistance, like small molecules. We have drugs that affect epigenetics, immunotherapy, immune engagers, cell therapy. So by being able to take advantage of this incredibly broad portfolio, either by using these drugs by themselves or in combination with each other, we really aspirate to attack cancer from multiple angles, because cancers are smart. They'll do whatever it takes to dodge whatever you're treating them. So we really can engage several of these mechanisms of actions to fight cancer. The other thing that is important is to recognize that the earlier you treat a cancer, the more effective you're going to be in your treatment. Because cancers over time, they will figure out ways to dodge the different treatments that are deployed against them, and they become stronger and stronger and more resistant over time. So if we're hoping to cure people in the metastatic setting, it's going to take a while for us to get there. But if we treat people effectively in the early setting, where the cancer has not quite clued in of how to get smart, that's when you actually make a big difference in preventing that metastatic recurrence that ultimately kills patients with breast cancer. So deploying treatments early, effective treatments early, is the way to go. And again, taking advantage of smarter treatments that are really honing in on what is driving that cancer growth is really the most effective way to tackle this problem. We are trying to engage new technologies. I mean, most of you have heard on the ctDNA thing. I know you're going to have a talk really right after mine with my colleague Ben Hopark, who's going to talk about liquid biopsy. So again, being able to leverage the detection of tumor fragments in the form of like tumor DNA within the bloodstream is actually quite powerful, not only as a detection method, but also as a following method, like to see if treatment is working or not working. And, again, we are in the era of technology. We are in the era of AI. It would be foolish not to take advantage of all this to actually improve our diagnosis, our detection of biomarkers that are relevant, how to do our clinical trials more effectively, where we take advantage of digital health to have our trials be more patient-centric and, again, at the end of the day, improve outcomes for everyone. So we have a lot of clinical programs of the future where, from a clinical trial design point of view, we are really taking a lot of time to figure it out how to make clinical trials more accessible, smarter, clinical trials that can read faster and bring drugs faster to patients that really need them. We want to make things patient-centric and we want to make them sustainable. So decentralizing some of the care, I mean, let's face it, COVID has taught us a lot. I mean, we now have the benefit of telehealth. And from a clinical trial perspective, maybe patients that live 5 hours away to a center that has the clinical trial does not have to travel that often, and a lot of things can be decentralized. So again, a lot of the internal processes are being changed, where slowly but surely we are changing the ways we are conducting clinical trials to be able to bring, again, options for patients when they don't have options close to them. So what is our ambition? Big scheme of things, we want to eliminate breast cancer as a cause of death. Let's acknowledge that certain diseases today, let's take AIDS, for instance, right? In the 80s, it was a death sentence. People would get AIDS, they died, and they died quickly once the symptoms started. But now, with highly effective treatment for AIDS, that has become a chronic disease, and honestly, very few people die of AIDS if they have access to the appropriate medications. We want to do the same with breast cancer, where perhaps someone dies with breast cancer, but we don't want them to die of breast cancer. And that is becoming a reality today for many, many, many patients, especially if they are diagnosed in older disease. But while we do that, we also want to make sure that we're not impacting quality of life, where the quality of life of a patient with breast cancer should be the same as the quality of life of someone without cancer. So trying to improve not only outcomes from a survival point of view, but also from a quality of life point of view really is our overarching goal. So the way we will do that is, as I said, by making our clinical trials more efficient, more patient-centric, taking incredible pride of being able to use a very, very large portfolio of drugs that helps us get there. And then we deploy partnerships that are meaningful with community centers, academic centers, and otherwise to help us get there. Because obviously, as a company, we're not the ones seeing the patients, but physicians are, right? So making sure that physicians and patients are aware of what's available to them is incredibly important, because that's the way we were going to advance science, by having people participate in clinical trials where maybe they get the drug of the future right there and then, but even if that's not the case, they still help advance science. There's no other way to do this. So this is just a snapshot of some of the drugs in our portfolio. And this is across the whole portfolio. Obviously, a lot of these drugs apply to a multitude of other cancers, but the ones that I've circled in red are the ones that are very relevant for our breast cancer portfolio. And again, a lot of them have already been approved. Some of them are now in phase 3 trials, some of them in phase 2, and some of them still in phase 1, but quickly transitioning to phase 1, 2, and 3 trials. And as you know, phase 3 is that last step before a drug can be proven or not to be better than what we're doing today as standard of care, and eventually get registered and usable at large. So again, a very large portfolio spanning across a multitude of different mechanisms of action. So what is our strategy? So how do we do this? How do we deploy this portfolio? This is a busy slide and complicated slide, but I'm going to get you through it so you understand what my vision is on how do we improve outcomes in breast cancer. So the way I divided the slide is in the different subtypes of breast cancer that exist today. About 20% of breast cancers fall into the category that we call HER2-positive breast cancers. These breast cancers today actually have completely changed in terms of outcomes compared to 20 years ago. 25 years ago, these cancers were the most deadly breast cancers out there. People would get a HER2-positive disease. They would have massive amount of burden of cancer when diagnosed, quickly progressed to metastatic disease, and from metastatic disease, they quickly died. The overall survival for HER2-positive breast cancer 25, 30 years ago was maybe at best 2-3 years, if that much. Then came medications that targeted the HER2 oncogene, and that was completely transformative for the field of HER2-positive cancer, where the fact that these medications shut down, quote unquote, that HER2 oncogene drive, that allowed the cancer to lose that quote unquote invisibility shield that made them completely resistant to standard of care treatments like chemotherapy or otherwise. So these HER2 targeted treatments have allowed cancers that were HER2 positive to now respond really well to chemotherapy, hormonal agents, and otherwise. And today, someone that gets diagnosed even with metastatic breast cancer can live over 5 years before they die. Now, in our portfolio, we have a drug that's called Enhertu, or trastuzumab deruxtecan, which is a drug that belongs to a class of drug that's called antibody-drug conjugates. Antibody-drug conjugates are actually an incredible, elegant way of delivering chemotherapy. Essentially, the idea is that you have a portion of that drug that is the antibody. So think of a keyhole type of thing, where if you have a receptor in your cancer, that is, in this case, the HER2 receptor, the key that would link to that keyhole, to that receptor, is the antibody. So this is a drug that has HER2 as the antibody, and it has what we call a warhead or a payload, which is the chemotherapy per se, which in case of Enhertu is a drug called deruxtecan, which belongs to a chemotherapy class called topoisomerase 1 inhibitors. Topoisomerase 1 inhibitors are actually quite relevant in HER2-positive cancers because topoisomerase 1, the gene that creates this protein that is instrumental to deal with your DNA, sits in the same chromosome where your HER2 oncogene may sit. So there's some sort of a love-hate relationship between these two genes. And therefore, drugs that tackle the topoisomerase 1 gene and consequently the protein are actually quite active in HER2-positive disease. So when you have an antibody that links to HER2 and internalizes this very powerful chemotherapy inside HER2-positive cells and very little on HER2 cells that are not affected by, that do not have the HER2 target in there, you actually improve tremendously the delivery of very high doses of this particular chemo, which now is incredibly effective in killing HER2-positive cells. This particular antibody-drug conjugate also has a different property that we call bystander effect, where it kind of seeps through to the neighboring cells, and therefore the magnitude of effect against the tumor is very, very high. So clinical trials now that have been done in second and third line HER2-positive metastatic breast cancer have shown an incredible advantage in augmenting what we call progression-free survival. And that has translated into a very meaningful overall survival for these patients, where even in second line, 16% of patients till today, once they started the original clinical trials, are still alive 5-7 years later without evidence of disease. If that is the case, imagine what happens when these drugs now translate into the first line setting and to the early setting, where you have a drug that is a blockbuster, incredibly effective, where now curing HER2-positive cancer, not to mention in the early setting, but even in first-line setting, may become a true reality. So the idea here is to really bring the Enhertu now, it's already approved for second and third line, but to bring it to first line and in the early setting, where the curability of HER2-positive disease can reach unparalleled and unprecedented levels, where perhaps all patients with HER2-positive disease can now be cured in the early setting, and a big substantial amount of patients in first line can also be cured as well. I'm going to skip the middle ground for a second and go down here, because the middle ground, I usually leave it for last because it's the most common type of breast cancer that we call ER positive or hormone receptor positive disease. Moving to triple negative breast cancer, here we want to redefine what that means. Why? Because triple negative breast cancer gets this name by being the cancer that doesn't have estrogen, progesterone, or HER2 receptor expression. So it's a disease that's defined by what it's not, and that's pretty lame. I mean, like, come on, we can do better than that. We, again, era of AI, so much that we've learned from disease biology. Can we really not find what the heck makes this cancer stick? So that is the endeavor. But so far, we haven't really been able to find a unifying biomarker that actually is, just like HER2 is to HER2-positive cancers, what really is that one-size-fits-all for TNBC. So we acknowledge that in TNBC, the one-size-fits-all is not going to happen. So it's about detecting subsegments of TNBC that potentially we can target individually and collectively make a difference in this cancer. For now, there are two things that floated to the top that really made a difference in triple-negative breast cancer. One was immunotherapy. This is something that we really didn't believe it was possible until we saw the outcomes for patients with melanoma, renal cancer, lung cancer, whatnot, and we realized that immunotherapy is an incredibly powerful weapon against a multitude of cancers. In breast cancer in general, triple-negative breast cancer is the one subtype that actually responds to immunotherapy. That is true in the early setting, and that is true in first-line setting. In later lines, that has not turned out to be the case. The more heavily pretreated a patient gets, the less is chemotherapy also knocks out what we call T cells, and you need your T cells to have your immune system react against your cancer. If your T cells are not working that well, and that unfortunately happens with chemo, immunotherapy is not going to work either. So the later you treat someone with immunotherapy, the less likely this is to work. But nevertheless, immunotherapy today, it's approved for the treatment of early triple-negative breast cancer, and it's approved for the first-line treatment of triple-negative breast cancer. The other type of treatment that also floated to the top as being something really effective against triple-negative disease is what we call an antibody-drug conjugate against TROP2. So similar idea to Enhertu, an antibody with a payload, except that the antibody here is against this receptor called TROP2, which is super widely expressed in triple-negative breast cancer. Like 90% of triple-negative breast cancers have it, and not a lot of things in your body have that either. So again, deploying antibody-drug conjugates against TROP2 that deliver, again, a similar topoisomerase 1 type chemotherapy into the cells, which triple-negative breast cancer has improved overall survival in the metastatic setting like there's no tomorrow. So what we really want to do now is be able to combine a TROP2 ADC with immunotherapy and bring it earlier, bring it to the first line and bring it to the early setting, where with that, we do believe that this is going to be better than just chemo and immunotherapy as we see today. In BRCA mutated, and not only BRCA mutated, I mean, most of you have heard by Dr. Orr that PALB2 mutations behave the same as BRCA mutations. CHEK2 mutations, similar, but not quite the same. But here we have an opportunity to expand on top of things such as PARP inhibitors that have already been ingrained in the treatment of germline BRCA mutations. And we have a new generation PARP inhibitor that is less toxic. It's a PARP1 selective inhibitor. And therefore, by being as effective, potentially even more effective than the current PARP inhibitors and less toxic, we would be able to combine them with standard of care drugs that for patients that have mutations and develop metastatic disease or even in the early setting, these drugs could be transformative and again, augment the cure for germline and somatic mutations that may drive tumor growth. So, best for last, this has been my area of research throughout my whole academic career. ER-positive disease, as many of you may or may not know, is by far the most common breast cancer. It's 65% of breast cancers fall into the category we call estrogen receptor or progesterone receptor positive tumors with HER2 negative status. HER2 positive tumors, even if they have estrogen receptor, still get lumped with the HER2 positive tumors at large. As such, the biggest killer in breast cancer still lays within ER-positive disease, just because of the sheer number of patients that develop this. So if we want to make a difference in breast cancer in general, in terms of survivability, our biggest efforts really need to be deployed within this type of breast cancer, because this is, as I said, the most common type and the one that still suffers from what we call late recurrences. Even people that are diagnosed with low-risk disease, stage 1, stage 2, sometimes 20, 30 years down the road may develop a late recurrence and still succumb from metastatic breast cancer. And therefore, efforts to prevent that and ameliorate outcomes in the metastatic setting are incredibly important to change outcomes in general for breast cancer, just because of how common this cancer is. Here we have a three-pronged approach of how do we want to tackle this. Acknowledging that in early setting, there's a subset of patients that are going to do well with what we call standard of care treatment today, which for these patients, for the most part, involves some sort of anti-estrogen treatment like tamoxifen or aromatase inhibitors. These patients, we probably cannot make outcomes better because they already have great outcomes to begin with. But there's a subset of patients that have high-risk disease that, as I said, tend to have recurrences early, midterm, or later in their patient journey. And they are the patients that, for the most part, end up comprising the group that develops metastatic disease. About 30% of patients develop metastatic disease from the get-go. They were never diagnosed with early disease, but 70% of patients with metastatic cancer come from recurrences that happen from the early setting. Throughout the patient's journey, a patient with high-risk disease will be exposed to chemotherapy early on. And after completion of chemotherapy, surgery, and whatnot, they will require 5 years at minimum of anti-hormonal treatment. Once they recur in the metastatic setting, treatment does start with anti-estrogen treatment, most of the times in combination with a targeted treatment, but at some point, the cancer stops caring about anti-estrogen treatments and requires the use of chemotherapy. So the idea in ER-positive disease is where chemotherapy is relevant, we want to replace that with an antibody-drug conjugate. And where hormonal treatment is relevant, we want to establish a better endocrine treatment as the backbone with a drug called camizestrant. And for metastatic patients that take estrogen, anti-estrogen treatments in combination with targeted drugs that help circumvent primary and acquired resistance to endocrine therapy, we want to build on this camizestrant foundation and combine it with relevant targets that help optimize the time that one can benefit from endocrine treatment. So that is essentially at large the breast cancer strategy, where collectively we hope to move the needle from where 5-year overall survival sits today at 85% to over 90% by 2030. And again, perhaps it may not happen in my lifetime, but by 2040, we want to get closer to even 100%. So I'm not going to go through the slide in detail, so don't fret. I know this is a super busy slide, but this is actually the clinical trial representation of this. So the way this comes to life in terms of breast cancer clinical trials is this. So we have trials that are already read. They already yielded results and have become standard of care. These are the trials in light pink. We have ongoing studies. The ones that don't have the green rim around them are studies that are almost about to complete accrual and should be reporting soon. The studies that are in purple but have the green rim is studies that just activated. And the studies in green are studies that have been approved by our governance and are ready to deploy and activate very quickly. And lastly, we have some studies in planning. And as you can see, there are not many because there's not a lot of white space. I mean, I went like all like world domination in here. I really wanted to pace. If you have breast cancer, you should be able to benefit from a clinical trial. And that was my idea. Like, have a clinical trial for whoever presents with breast cancer at risk of recurrence or with recurring disease, so you can hopefully benefit from this. So not a lot of white space. And let me guide you now in a few details of what we're doing in all of these different spaces. So again, I'm not going to focus a lot on this slide, just to say that we have a ton of clinical trials ongoing throughout the world, not just in the US. So ER-positive breast cancer, complicated field. It's really treating metastatic breast cancer that is estrogen receptor positive today. For physicians, it's actually a little bit of a nightmare because they have to be able to recognize the right patient for the right drug at the right time, and things shift faster than quicksand. So patients that get diagnosed with metastatic disease and are about to start their first line of treatment, they come in all shapes and varieties. There's a lot of things from a clinical point of view that determine their outcome, their ability to respond to different treatments. And it's a spectrum where the majority of patients benefit from starting some sort of endocrine treatment with combinations from the get-go. But over time, there's a loss of clinical benefit to endocrine therapy, where at some point, as I said, the people stop caring about estrogen receptor strategies and really needs chemotherapy. So acknowledging as a patient gets diagnosed, where the heck are they going to fit in this continuum is important, because again, I cannot stress the importance of really fitting the right patient with the right drug at the right time. And if you screw that up, you won't be maximizing the potential outcome that that patient has. So this is a very dynamic, heterogeneous, and complex field where physicians have to be able to recognize where within the spectrum this patient is going to fall. Therefore, there's not one size fits all treatment here. It really is very individualized depending on where this patient is presenting. Is it first line? Is it second line? Is it third line? Is it within a spectrum of benefit of estrogen treatment? Is it up here? Is it down here? So you need to like simultaneously think about all of those things when you're thinking about how to treat a patient there. This is a complicated schematic of how do we approach metastatic disease today. And honestly, it starts with recognizing how much burden of disease one has. What was the previous treatment in the adjuvant setting? Or is this treatment from the get-go? Is this person having so much disease that they cannot even function and you need to shrink the disease super quickly? Or is this someone that even though they have metastatic disease, they have like 1 or 2 dead cells in their bones, but they're like completely normal otherwise? So all of this presentation dictates what the heck is going to be your first treatment and what are going to be your subsequent treatments. So there's a lot of choices, but at large, first treatment for the most part is a combination of a drug called CDK4/6 inhibitors. There's 3 of them approved right now. One is called Kisqali or ribociclib, one is called Verzenio or abemaciclib, and one is called Ibrance or palbociclib. And either one of these 3 drugs is given in combinations with endocrine therapy. And again, many of you may recognize names as tamoxifen, letrozole, anastrozole, exemestane, or Nolvadex, Arimidex, and Abromycin or Femara. Like all of these drugs are already approved. And again, the combination of these drugs are the absolute standard of care in first line for the majority of patients in ER-positive metastatic situation. But then second line becomes, in my view, wild west. I mean, what to do at that point is like up for grabs because there's no unifying treatment that is standard of care. There's like a lot of options and you just need to figure it out. When your patient gets there, what is the option that they may benefit from the most? So today we have genomic testing that helps us to some extent identify patients that have a biomarker that may benefit specifically from a treatment, but there are patients that don't have any of these biomarkers. So if you happen to have a mutation in this gene called PIK3CA, you would benefit from drugs like alpelisib or Piqray, and a soon to be approved drug called capivasertib or TrueCap in combination with endocrine treatment. If you don't have a mutation in PIK3CA, now you still need to look if you have a mutation in this gene called ESL1, which is the estrogen receptor gene. If you do, you may benefit from one of these new next generation SERDs, like there's one approved now called elacestrant. But if you don't, then you may use things like regular endocrine therapy in combination with mTOR inhibitors like everolimus, or even by themselves. And then if you have a BRCA mutation, after that, you may want to use something like Lynparza or talazoparib or whatnot. And if you don't, then that's the time when you would consider either an antibody drug conjugate like Enhertu, or the TROP2 antibodies like sacituzumab or Trodelvy, whatnot. And only after that you transition to chemotherapy. But by the time people get down here, they don't have a lot of time left. So our way to improve outcomes is by improving what's going on up here, because once the cancer gets to this point, that cancer has gone, forgive my French, batshit crazy, and there's not a lot you can do. So this is where you can actually impact outcomes for patients with ER-positive disease. So going back to our strategy, what have we done so far to replace chemotherapy where chemotherapy is relevant? So replacing chemotherapy by the time when patients get down here is something that we have accomplished with this drug called Enhertu or TDXD. This was a presentation at this large conference. You all are familiar with ASCO, I would assume, in 2022, where this drug, TDXD or Enhertu, was compared to standard of care chemotherapy after patients have exhausted endocrine treatment with targeted treatment in metastatic disease, and were in their second line of chemo. And this not only has improved almost double progression-free survival, but has incredibly impacted overall survival. And thanks to this drug is now approved for second-line treatment for patients with ER-positive metastatic breast cancer. Just literally 2 weeks ago, we now have another antibody in that space called Dato-DXd. This is an antibody that is very similar to one that's already approved called Trodelvy. The way this differs by Trodelvy, not as much in terms of efficacy, this is very similar because it's also a TROP2 ADC, but where this drug wins is in quality of life. Safety was way, way, way better compared to the currently approved TROP2 ADC. Why? Because patients don't get nearly as much drop in their blood counts. So the risk of having fever with a low blood count that takes people to the hospital at risk of sepsis is not there. This drug also does not cause, I know for you guys may not be that big of a deal, but believe me, for women, losing their hair is a big deal. So this drug doesn't cause minimally as much hair loss as SASI does. But most importantly, this drug is much safer, where the side effects that people get are not side effects that are going to kill you. You don't get violent diarrhea. You don't get violent drop in your blood counts with fever and sepsis that can kill you. So it's a safer drug, super well tolerated, and just as efficacious, if not a little bit more efficacious than Trodelvy. So this is now a new option for patients with ER-positive metastatic breast cancer, where they can use either Enhertu if they have enough expression of HER2 in their tumor, like they need to have at least a teeny little bit of expression to benefit from this. If they have no expression whatsoever, now that becomes a really great choice for patients that, again, it's super effective and super safe. Now, for patients that require hormone receptor targeted treatment, so estrogen, anti-estrogen agents, so endocrine therapy, let's see what this drug camizestrant and others can do in this space. So remember, what we wanted to do here is improve the efficacy of current endocrine treatments and build on these drugs with smarter targeted treatments to improve outcomes. So when a patient gets diagnosed with in first-line metastatic disease, they come again in all types of flavors, right? About 30 to 40% of patients will be and this is again globally, don't think just US, think around the globe where people don't have as much access to optimal care as we have in the US. We are actually very lucky. But nevertheless, a lot of people present with metastatic disease from the get-go, but the majority of people still have recurrent disease from when they were diagnosed in the early setting. But within this recurrent disease, you have very different flavors of when that happens. Sometimes that progression happens very late. You may have completed treatment in the adjuvant setting, many years ago and whatnot. And these patients clearly retain a lot of sensitivity to anti-estrogen agents. Whereas patients that recur fairly quickly from completing their adjuvant treatment with an anti-estrogen agent, or even within that treatment, they don't have as good of a behavior and they don't benefit as much from endocrine treatments. So we have different clinical trials for these patients. We have a trial that interjects this camizestrant for this first-line patients that have exquisite sensitivity retained to endocrine treatment. And for the patients that don't, we don't believe that improving on endocrine therapy makes sense. Here, what you have to improve is the targeted treatment, because these cancers don't care as much more for anti-estrogen treatments. And we know that combining our camizestrant, our best estrogen treatment, and the reason we call it best is because the suppression of estrogen that this drug causes compared to what's out there now, it's way higher, with targeted treatments against what we call the AKT survival pathway, which is a cascade of proteins that talk to each other, and they are supposed to maintain your cell alive. Once a cancer is exposed to estrogen treatment, the cancer tries to figure out a way to continue to stay alive. And what it does, it takes advantage of this cascade of proteins on this survival pathway and hyperactivates, it jacks up the function of these proteins. So this drug, capivasertib, is a drug, or TrueCap is a drug that tackles specifically either mutations in this pathway, so PIK3CA mutations, AKT mutations, PTEN mutations, or it tackles the activation of the pathway even in the absence of mutations. And when you combine the drugs like Cami and Capi, either by themselves or even with drugs like a CDK4/6 inhibitor, the activity is seen and is better than anything else, even in the absence of mutations. So there's a synergy that happens there where you tackle estrogen, the estrogen pathway in a stronger way, but you also take away the compensatory mechanism of resistance that cancers may engage. So with that, we have clinical trials that are combining Capiva with estrogen treatment and a CDK4/6 inhibitor. This trial is about started. It's active throughout the US. So for patients that are what we call these fast progressors, this is a great trial for them to participate into. But in second line, once patients progress in first line optimal treatment, what we figured that makes a lot of sense is combining camizestrant, again, the best estrogen treatment, with Capiva. And this is what the SERENA-8 trial is all about. So these are for patients in that wild west situation, second line, where we believe that this combination is going to be better than anything else that's a choice out there. So this is a trial that will become active in the beginning of next year, probably by May-ish of next year. So this will be a wonderful choice for patients that have progressed on estrogen treatment, CDK4/6 inhibitor in first line, and now potentially can benefit from the true drugs that tackles the most important mechanisms of resistance that plague these patients. Now, what about early? In early, we also want to replace chemo with an ADC, but we're not there yet. This trial is still under construction because a lot of the landscape has shifted. But here we want to bring camizestrant, this best estrogen treatment, to the early setting as well. And the way we do it is by acknowledging that patients in early setting also don't come in one single flavor. The patients that have low risk, honestly, they're doing fine with whatever they have, but the patients with high risk, they come in two main flavors: the patients that will recur early, and those are the patients that have high burden of disease and high biological risk, high-grade tumors, high Ki-67 and whatnot. And then there are patients that are going to recur later, which are the patients that either have large burden of disease but low low biological risk, or patients that have high biological risk, but low clinical volume of disease. So acknowledging that the spectrum of when these cancers recur is different, it's foolish to think that one clinical trial design is going to tackle both of these patient populations, because that's a continuum. So you won't really have a great way of covering all this and taking care of all this with one single trial. So we figured that two trials are required for that. One trial that interjects this drug, camizestrant, later in the game, and that's to capture these patients that are at risk for later recurrence. And a trial that interjects this drug early, where this is for patients that will have an earlier pattern of recurrence. And that's why these trials called Cambria-1 and Cambria-2 are all about. And again, Cambria-2 randomizes patients from the get-go whenever they are about to start their endocrine treatment, where you get standard of care endocrine treatment for 7 years or camizestrant for 7 years, and the use of a CDK4/6 inhibitors is up to the physician and the patient. And Cambria-1, which is for those intermediate risk patients, randomizes them later. You may have had 2 to 5 years of regular standard of care treatment before being randomized to an additional 5 years of these drugs. So why this longer duration of treatment? The reason this is the case is because for patients at high risk of recurrence, prolonging estrogen treatment to at least 7.5, 10 years is better from a survival point of view than just doing 5 years. And that's why these trials have a long treatment duration. But again, collectively, both of these trials give options to patients at intermediate risk, patients at high risk, and even for patients with a BRCA mutation. Cambria-1 is still a trial that can be used after the completion of Lynparza in the adjuvant setting when that is appropriate. So moving on to BRCA mutations, we have this new PARP inhibitor called saruparib. As I said, it's a new generation because it's a PARP-1 select inhibitor, less toxicity than is seen with Lynparza and other PARP inhibitors. And what we notice is that in patients with BRCA mutations, in the metastatic setting, there's an enrichment of another mutation in ESR1 when they have ER-positive disease. ESR1, as I mentioned, is the mutation in the estrogen receptor gene. And what this mutation does, there's resistance to the current estrogen treatments. But this drug camizestrant, which is a new generation endocrine treatment, is active against these mutations. Therefore, if in patients with BRCA mutations, we see a lot of ESR1, it makes sense to combine them. And furthermore, patients that have BRCA mutations in first-line treatment of metastatic disease, they don't do so well as patients without BRCA mutations, where the response to a CDK4/6 inhibitor and conventional endocrine treatment can lead to, sometimes 2+ years of benefit, sometimes even more. But for BRCA mutated patients, this benefit doesn't last about a year. So the idea here is to combine this new PARP inhibitor with this new generation endocrine treatment against this, just to see from a contribution of component point of view, if you really need the new PARP inhibitor early on or not. But we believe that either one of these two strategies here will be better than the conventional treatment that we use today. By bringing a PARP inhibitor sooner, we should be able to prolong progression-free survival for these patients in first line and normalize their outcomes compared to patients without BRCA mutation. In triple-negative breast cancer, the treatment in metastatic disease today is incredibly limited. We divide patients into the ones that have tumors with PD-L1 expression, which tells you that they respond to immunotherapy, and patients with tumors without PD-L1 expression, where chemotherapy is really about the only thing you can get. Immunotherapy, as I mentioned before, has improved survival, but is delegated to first line. When patients progress to second line, if they have a BRCA mutation, they get tremendous benefit from a PARP inhibitor. But if they don't, they can use an antibody-drug conjugate like that TROP2 antibody-drug conjugate. But after that is blown away, and both PARP inhibitors and ADCs in this setting have it's chemotherapy. And when it gets to that point, patients may not live longer than 6 to 8 months at best. So the metastatic treatment is pretty dismal because there are limited options. In early disease, it's not one size fits all, where we have patients that some of them are super low risk or low risk altogether. That's not very common in triple negative disease, I should say, but they benefit either from no treatment or an abbreviated adjuvant chemotherapy treatment. And these patients do well with this. But for patients that have high risk disease, stage 2 or stage 3, immunotherapy now has become a staple, used along with chemotherapy. And this is done in what we call the neoadjuvant setting, where you start with the chemo, shrink the disease as much as you can. And at the time of surgery, if you shrunk the disease to oblivion, where you have no disease left behind, you continue immunotherapy for another 6 months or so, and you're done. And outcomes are awesome. Like the odds of recurrence are less than 5%. But if you have residual disease, then we are in a little bit of trouble. If you have a BRCA mutation, you can benefit from using Lynparza for a year. Some patients and physicians opt to add immunotherapy to that, and that has improved survival. But the patients that don't have that option, then their option is to continue immunotherapy with or without a chemo called capecitabine, but the outcomes here are still pretty dismal, where 40% of patients still recur despite all this treatment. So what are we starting to do in this disease? Still beginning, not super creative, but the idea is to exchange current immunotherapy and chemotherapy where relevant, which is pretty much everywhere in here, for a better cytotoxic treatment in a form of an ADC, so Dato-DXd, which is that TROP2 ADC that is super powerful and safer than the current TROP2 ADC that is approved today. And the idea is to plaster it everywhere, specifically in the early setting, where perhaps we can take that curability potential from 60% to 80%. So we have belief based on our phase 2 trials, especially this trial called Begonia, which is a trial that combines this ADC, this TROP2 ADC called Dato-DXd with Durva and immunotherapy in patients with first line. These are patients that are unselected for, this is both PD-L1 positive and PD-1 negative patients, where what we see here is unprecedented. To put things in context, today, the response rates that we see in first line, and this is again for patients with PD-1 positive disease only, response rates are 40%, median progression-free survival is about 7.5%, 9% at best. With this combination, we are seeing 14 months progression-free survival, so double, and response rates are also double. So that's why we are so excited about pasting it everywhere, because we really believe that this can double the efficacy that we're seeing today with conventional treatment. So we have 2 trials in first-line metastatic, one for PD-1 negative patients with Dato only, one for PD-1 positive patients with Dato and Durva. And then for early disease, we have neoadjuvant treatments trying to put Dato Durva in there against what currently is standard care, chemo and immunotherapy with Pembro. And in this way, we also have a trial for residual disease for those patients that don't achieve a complete pathological response, which again, we're exploring Dato and Durva or Dato alone compared to whatever we have today, which is not much. So with that, we really do believe that we would change outcomes for these patients with triple-negative disease, but homework there does not stop here. There's a lot more we can do, and the next wave of things is to spruce up immunotherapy by bringing some of what we call the bispecifics in, which are now in super immunotherapy that are more active than the conventional ones. And lastly, for HER2 disease is just to show you what we can do, what we can dream of with Enhertu T-DXd, just based on what we've seen even in second-line metastatic, where if we are seeing cures there, imagine what this drug can do in first line and in early disease. And with that, I'm going to stop here and perhaps stop sharing my screen where I can take questions. And again, thank you.